The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. Tonight we are going to talk about one of the basic problems that diabetics have, one of the diabetic complications, what we call the microvascular complications of diabetes, diabetic neuropathy, and specifically diabetic peripheral neuropathy. But before I go into that, by the way, I'm Dr. Claude Khan. My wife, Linda, is not with me tonight, so you're going to have to cope with me. And I wanted to make a few comments about the influenza virus and the various theories about it, and the various theories about the immunization itself. You know, I've seen various things on Facebook coming onto my WhatsApp inbox talking about encouraging people not to take the influenza vaccination. There was one well-known fitness coach who was encouraging people not to take the influenza virus. And there's a lot of talk about mercury poisoning and all kinds of weird and wonderful things. I want to say to you that you need to go to the right sources to get the right information. What amazes me again and again, and maybe as I get older, I'm becoming more and more outspoken. People without 1 day of medical school training, without 1 day of medical training, they've probably read, Googled a lot, and they feel that they have the expertise to talk about immunizations. And so people are being encouraged not to take the influenza vaccination. I think that's sad because obviously, many will be influenced by this information because many people masquerade as health professionals when they have no training. And I always tell you, when you go to someone, you should ask. Feel free to ask, where did you get your medical training? It might be a diabetes educator, it might be a nurse, it might be a physiotherapist, an osteopath, or a medical doctor. You should feel free to ask, where did you get your medical school training or your medical training? Can I just say that although there's an outbreak of the influenza virus, traditionally, countries with a winter period would be those that would be encouraged to take the influenza virus. Now we are encouraging people in Trinidad to take it. And there are certain high-risk groups, children under 2 years old, people over 60 to 65, people with diabetes, asthma, hypertension, or who have had heart disease or who have heart disease. So elderly people, people with chronic non-communicable diseases, and very young children. Those are the high-risk groups, or people who are immunocompromised, people having chemotherapy, etc. And yes, it is true that you're injecting, like most of the vaccinations, some of the antigen, some of the virus. But if you understand how the body works, and you know, it's sad again when people make comments not understanding, the way you prime your immune system is by being exposed to the particular antigen. So when the real virus affects you, your body is already primed and your immune system is ready to fight off the infection. So what I would encourage you to do is get the right information from the right people. And can I just remind you that immunizations are not bad. In fact, if you look at the last century, some of the most important discoveries have been immunizations. Polio immunization, the smallpox immunization, measles, mumps, rubella, tuberculosis, TB, the BCG vaccination. Many diseases have been eradicated because of immunizations. How can all immunizations be bad? Please be informed. If you need more information, I want to just give you some of the numbers you can ring and some of the forums that you can contact us on. 482-4269. The number is up there, 482-4269. You can visit our website, www.anaposiscommunity.com. You can follow me on Facebook. You can search for me, Claude Khan. I post a lot of medical articles, including, and in addition, a lot of other articles on Facebook from WebMD and other sources, or you can follow me on Twitter. And by the next show, I will give you my Twitter handle, as we call it. So you can, or you can just search for me on Twitter. You can follow me on Facebook. You can email me on claude_khan@yahoo.co.uk, or you can look at our website, www.anaposiscommunity.com. So that was a little bit about immunizations, and I thought I needed to say that at the start of our show because it is a very topical issue. So we're going to talk about diabetic neuropathy. Now, diabetic neuropathy is a broad term that includes diabetic autonomic neuropathy, and that's neuropathy affecting, for example, the emptying of the stomach, which is called gastroparesis, diabetic autonomic gastroparesis, where the stomach is not emptying at the right rate. You have diabetic autonomic neuropathy affecting the heart. You could have a dilated cardiomyopathy. You can have arrhythmias associated with the heart. You can have erectile dysfunction due to diabetic neuropathy. You can have a diabetic mononeuropathy. By that I mean one particular area, for example, the thigh may become numb or very painful. You have a form of neuropathy, which is a diabetic painful neuropathy affecting just one part of the body. But the most common type of neuropathy, and I see numerous patients with this, is diabetic peripheral neuropathy or diabetic peripheral sensory neuropathy. And it's affecting the nerve ends to the feet and sometimes the hands. And it is a very, very common symptom. One of the most common symptoms I see in my day-to-day practice. I want to bring up slide 3. And slide 3 shows you what I would call diabetic foot disease, the high-risk foot. And what makes this particularly diabetic foot disease particularly high risk is that you very often have peripheral neuropathy and peripheral vascular disease overlapping. So we could just come off that slide, and I will explain that to you. So and we're going to talk, if we have time tonight, about peripheral vascular disease, or we may have a separate program for that. But very often in diabetics, we have an overlapping of peripheral neuropathy and peripheral vascular disease. And both these conditions lead to, in terms of neuropathy, we have numbness and decreased sensation in the feet. And then because of peripheral vascular disease, you have poor blood supply. And those two overlapping problems can often lead to a high-risk foot. In other words, if a diabetic has neuropathy and peripheral vascular disease, then if they get a foot ulcer, it puts the foot at extremely high risk. And that is why I want to say right off, for many of our diabetics, aspirin therapy is important. Cholesterol tablets, statins are important. And again, there's so much misunderstanding, and that's why I'm revisiting this whole particular area tonight and on these programs for the next 2 weeks. So I want to bring up slide 4, and what slide 4 shows us is some statistics. People with diabetes are 25 times more likely to lose a foot than people without diabetes. Now, that's an astounding figure. More than 1 million people lose a leg every year worldwide due to diabetes. That's every 30 seconds. And 70% of all leg amputations happen to people with diabetes. 5 years after lower limb amputation, up to 70% of people have died. Now, I want to come off that slide, and those are some frightening statistics. We are not live tonight. Let me remind you, that's why I gave you all the telephone numbers, and I'll repeat some of those because some of you may want to ring in, or you may want to email us, or post some questions on Facebook. Those are some astounding figures. Over 1 million people worldwide lose a leg every year. Now, that might be a below-knee amputation, or an above-knee amputation, or some people may not lose a limb, but they may lose toes. And that puts them at risk of further amputation. 70%, and this is an important figure, 70% of all leg amputations happen to people with diabetes. So diabetes is it is the main risk factor for lower limb amputation. And we have an extremely high rate of amputations here in Trinidad. And I'm going to address why that might be the case. And I'll tell you right off, we are not doing preventative care where our diabetics are concerned. We have no state-registered podiatrists on the government service. And I can say that very clearly, and I again say to the Ministry of Health, we are giving scholarships for various things. We need to aim our podiatry, foot care, as a high priority in our health service, so we can have people trained in foot care in our chronic disease clinics, and therefore diabetics can have their feet examined every 6 months or every year, and we can pick up problems at an early stage. And the last statistic is particularly frightening. 5 years after lower limb amputation, up to 70% of people have died. Why may that be the case? Well, once you have had a lower limb amputation, it means that you may have peripheral vascular disease. And if you have clogging up of your arteries to your leg, theoretically, you may have clogging up of your arteries to your heart as well and other parts of the body. So you may die of a heart attack or stroke. So a lower limb amputation is a prognostic indicator of a shorter lifespan, and that's something that's important to remember. I'm going to go to our first clip that gives us a little bit of an overview of diabetic neuropathy. So I want to go to our first clip before we go to our first break. I just want to take in our first clip at this point.
Watch diabetes videos at clearlyhealth.com.
A common complication caused by prolonged high blood glucose levels is nerve damage, known as diabetic neuropathy. Nerves are found throughout your body. They are responsible for everything you feel, from warmth and cold to pain. They also play a vital role in controlling your heart rate, digestive system, bladder control, and sexual function. Small blood vessels provide nerves with nutrients and oxygen required to survive and function. Your nerves are extremely sensitive to any change in their oxygen and nutrient supply. Damage to these small blood vessels occurs when blood, containing high levels of glucose, travels through them on its way to feed your nerves. When the small blood vessels are damaged, a sufficient supply of nutrients and oxygen no longer reaches the nerve, causing the nerve to become damaged and eventually die. The first sign of nerve damage occurs in the feet. It might feel like numbness, tingling, or burning. If left untreated, it can lead to complete loss of feeling and spread to other parts of the body. The area of the body most often affected by nerve damage is the feet. Small injuries such as a blister can be undetected due to loss of feeling. Left untreated, these injuries can become infected and, in severe cases, require amputation. To prevent injuries from progressing, it is important to conduct regular foot exams. This will not require much time and will help injuries from becoming serious.
For our full library of healthcare videos, go to clearlyhealth.com.
Right, so that gives you a brief overview of the nerves in the body. And so diabetic peripheral neuropathy, what basically happens is that the nerve ends are affected to the feet, as well as sometimes people get the same symptoms in the hands. I want to bring up slide 5. And slide 5 talks about how we can prevent. What is a prevention strategy? So 49 to 85% of amputations can be prevented through a care strategy that combines prevention, we have talked about that, a multidisciplinary treatment of ulcers, appropriate organization, close monitoring, and education of people with diabetes and health professionals. So I want to just talk about that a little bit. Prevention. So how can we prevent amputations? How can we prevent people from ending up losing limbs? Well, by having patients, educating patients how to examine their feet themselves. As you can see on that clip, the patient had a mirror and they were able to look under the feet. Of course, as people get older, it becomes increasingly difficult for them to bend over and to be able to examine the feet properly. Now, we have some nice devices, or you can make a device yourself where you have a mirror and you extend it below the feet, and you're able to examine whether there are any, there's hard skin buildup, whether there are any breaks in the skin, whether there's callus, etc. And that's an easy way of prevention. But of course, the other way of prevention is a multidisciplinary team. And when we talk about a multidisciplinary team, of course, that has been our goal, developing multidisciplinary teams on the government service. I have to say, we have had limited success because the problem is that very often the powers that be do not see the need to have the various healthcare professionals approved and their posts placed in the community. So a lot of the diabetes care traditionally have happened in the hospital setting. Well, diabetes is really a primary care setting specialty in the first place. More complicated diabetics, of course, need to be seen in a tertiary center. But by the time you refer diabetics to the hospital, they have already developed some complications of diabetes. If we increase the expertise in the community, we have doctors who have special interests and special qualifications in diabetes care, and we now have a few people like that. In the Southwest, we were leading in that particular area. If we have diabetes educators are a very important, in fact, might be the most important member of the team. And we've been able to train over the years Caribbean certified diabetes educators. Unfortunately, many of the regions have still not approved those posts. So again, I say to the Ministry of Health, you need to get the ball rolling and be able to get some of these people approved. And I talked about podiatrists, and there's a difference between people doing a pedicure and a state-registered podiatrist. A state-registered podiatrist is someone who has done a 3 or 4 year course and is able to do detailed surveillance and treatment of diabetic foot problems. We have to go to our first break. When we return, we'll continue our discussion on diabetic foot disease and diabetic neuropathy.
Looking for a safe place for the whole family? Well, now you've found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values and family first. We are ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. And just to remind you, we are, this is a tape program. We are still, maybe later on in the next month or so, we may go back live, so you can call in with your phone questions. But for now, you can ring us on 482-4269. The Anaposis Medical Center is based at number 10 Lance Street in Vista Bella. We also have a base in Chaguanas. And some of you have been seeing signs on the bypass in San Fernando. That's the church, the Trinidad and Tobago Anaposis Chapel. So really, the Anaposis Center, what we seek to do is deliver holistic care. The medical center is looking at medical problems from a holistic point of view. We have the church, and then we have Lengua Linda, which delivers Spanish, English, and what is called the English Speaking Board. And you can ring on that same number, 482-4269, for information. Just talking about the church, This program, we try to address things from a holistic point of view. I'm just going to show a clip now about a very important marriage conference that we have coming up on the 16th of February, Saturday, 16th of February, 2 days after Valentine's. And I want to encourage you to look at this and probably ring in and register for this conference. So we're going to go to that short clip right now.
Every husband has what his wife needs, and every wife has what her husband needs, but we can only get it if we serve each other. You have to sit down and you have to make a decision. I'm going to use my strength to serve, not to rule.
The depth of your honesty with each other will ultimately determine the depth of your intimacy. You can't have secrets and intimacy at the same time in a marriage.
Any problem that you're facing is really not a his and her problem, it's our problem. It doesn't matter what it is.
Husbands, show and prove your love.
So some additional numbers came up there. I am going to probably place those numbers on Facebook. Well, they will be on Facebook. So again, you can follow us on Facebook. You can follow me, Claude Khan, on Facebook, or the Anaposis Chapel, or the Trinidad and Tobago Anaposis Center. We have various sites on Facebook where we promote a lot of what we're doing. So just join us on Facebook, or you can follow me on Twitter as well as I promote some of these programs. So if you're interested, the number I would give you is the same number, 482-4269. It's on Saturday, the 16th of February, very important marriage conference. Those of you who are looking at me tonight and over the next week or two, if you're married, planning to get married, very important that you invest wisely in building a strong marriage. Coming back to the medical aspect tonight, neuropathy. The question is, what will place you at risk of developing diabetic neuropathy, and therefore putting you at risk of amputations, etc. I'm going to bring up slide 8, and this talks about the risk factors for diabetic neuropathy. So poor glycemic control. What does that mean? Poor sugar control. The higher your blood sugar, the longer you have diabetes. That's the second thing. The long duration will put you at risk of nerve end damage. Your age, well, the longer you have diabetes, the older you get. Your height, well, some people seem to think the taller you are, your neuropathy might be slightly worse. That's a little bit debatable. But excessive alcohol intake. Now, that's an interesting one because we don't often associate excessive alcohol intake with diabetic neuropathy. But actually, the two tend to overlap. And so if you're a heavy drinker and you have diabetes as well, your neuropathy can be complicated because, of course, excessive alcohol intake does cause a neuropathy in itself. So you can have a alcohol-related neuropathy, and then if you're diabetic and you're drinking heavily, you can have diabetic neuropathy and alcohol overlapping. But the 3 or 4 things, of course, is poor sugar control, poor diabetes control, poor blood pressure control, and poor lipid control. Those were not mentioned, but those are also risk factors for all the complications of diabetes, be it diabetic microvascular or diabetic macrovascular disease. Microvascular, talking about diabetes affecting the small vessels, and in this case, the small nerve ends, and diabetic macrovascular disease, diabetes affecting the large vessels, the vessels to the brain, causing strokes, the vessels to the heart, causing heart attacks and heart disease, and the vessels to the legs, causing peripheral vascular disease. Now, some of the common symptoms, and this slide will, slide 9, will probably bring to your memory a lot of what you experience. Slide 9. So the typical symptoms of neuropathy is burning, pins and needles, extreme pain. Some people describe as if their feet are on fire, tingling, shocking, a knife stabbing into the feet, or sometimes just like crawling sensation. So I just come off that. So patients come in to me, and they've been to a variety of people, sometimes before coming to me, and various things have been tried. Now, I want to say that there's no particular, we know why, some reasons why some people may have a more severe neuropathy because of years of uncontrolled diabetes. So let me just say this to you. The common scenario that we have with patients presenting with diabetes is that they sometimes go for a routine medical, or, for example, like this morning, I was at a school, and the staff had a staff day where staff members were encouraged to come in and see us and have their blood pressure checked and blood sugar checked. And one particular person came in, and their blood sugars were uncontrolled. Now, another one came in and was clearly diabetic, but didn't seem to have accepted the fact that they may have had diabetes for many years. So the common scenario is this. People may have diabetes for 4, 5, 6, 7 years, and it goes undiagnosed, or very often patients are in denial. They're not wanting to admit that they have diabetes or they have a problem. And the diabetes, the blood sugars are extremely high, damage is occurring. By the time patients come in and they see us, we begin to put measures in place. We begin to control their blood sugars, their blood pressure, their cholesterol, their lipid profile, etc. And this is one of the reasons I say to patients, once you know you are diabetic, there's no time to waste in terms of being treated effectively and on the basis of good science. I know I go on about this again and again, but there's a lot of fake medicine out there. A lot of people not trained medically, but trying to do medicine. And they're giving you false assurances that they can cure your diabetes. Can I say that I never talk about a cure for diabetes. I may say that your diabetes may go into remission, if you come in and you're very overweight and you lose a lot of weight, especially if you're carrying a lot of weight around the tummy area, and you lose a lot of body fat. That body fat regresses around the organs. So what happens with people who are very overweight? They have what is called visceral fat, not subcutaneous fat. So people who are doing liposuction, that's the latest craze, even in Trinidad. I'm hearing, and I'm quite concerned because liposuction is really a specialty area, and I'm hearing that people who are not plastic surgeons, etc., doing liposuction. You need to be careful about that. But liposuction does not remove visceral fat, does not remove fat from around the pancreas, fat from around the liver or in the liver. It just removes the superficial fat. Yes, if you're doing it just for cosmetic purposes, you'll have a good outcome. But that is not going to regress the visceral fat that affects the pancreatic function and the liver function, etc. So you need to be careful when you're being treated, that you're treated effectively and from an early stage. Now, I'm going to show a second clip that talks about foot ulcers. And this is someone talking as well, some visual images, and it's just a short clip on foot ulcers. So let's just go to our second clip at this stage.
Hello, I'm Dr. Torrance, a podiatry fellow at the University of Michigan. Two of the goals at Michigan Podiatry are to prevent diabetic foot ulcers and diabetic foot amputations. I'm going to discuss diabetic foot ulcers and what to do if you develop one. Remember, everything I share is only for your information. Before making any medical decisions, you should talk to a healthcare professional first. An ulcer or wound is a break in the skin, as seen here. The main reasons people with diabetes develop foot ulcers are loss of feeling in the foot, poor blood flow to the foot, increased pressure, or direct injury to the foot. Diabetic foot ulcers have a high risk of infection, especially if you've had one for a long period of time. The infection can spread from the wound to the bone. There are antibiotics that can treat bone infection. However, if the infection destroys too much bone, the bone will need to be removed or amputated to promote better healing and provide a better functioning foot. If you develop a diabetic foot ulcer, contact your podiatrist or healthcare provider right away so they can develop a treatment plan for you. Your treatment plan will include blood work, X-ray, or MRI. Your provider will also show you how to dress or cover your wound and how to offload your wound for better healing. Offloading means reducing pressure and friction to the wound for better healing. Offloading can be done through a total contact cast, as seen here, or through a wound healing shoe, like the one I am holding. The wound healing shoe has a special insert that reduces friction and can be modified to reduce pressure on your wound. Remember, a cast and a wound healing shoe is only temporary. Once your wound is healed, your provider will need to order diabetic shoes and custom inserts to prevent another ulcer. Some important things to remember. If your foot is painful, red, hot, swollen, has pus, and a foul smell, like the wound you see here, you should report to an emergency room immediately, as you may have a diabetic foot infection. This is very serious, as you may need IV antibiotics to treat your infection. Also remember to only clean your diabetic foot wound with soap and water. Do not soak your foot. Do not use bleach or hydrogen peroxide to clean your ulcer, as it can worsen the ulcer and the surrounding skin. Thank you for watching this video. I hope you've learned about diabetic foot ulcers and how to treat them. Remember, Michigan Podiatry is here to help you with all your diabetic foot concerns.
So that was a nice clip, obviously from the US. Person sounded as if she was from the Caribbean. So we have people in the US who could return home if they are paid properly and given the appropriate post. So again, I want to say that, and what that slide demonstrated was that there are various devices with someone with a foot ulcer that if they're in a proper foot combined multidisciplinary team clinic where you have a diabetic physician, you have maybe a diabetes educator, you have a podiatrist, a properly trained podiatrist, you have a dietitian, ophthalmologist, etc. You can be given some of these devices. The offloading pass, for example, which was very common in the centers in which we worked in the UK. That's almost 12 years ago or even more. So those devices have been around for a long time, and they should be available under government service. Now, why am I saying this? I know we are strapped for cash, but if you, to the Minister of Health, I say again, and to the advisors, the Chief Medical Officer, and the Directors of Health in the various regions, if you have a vision for diabetes care, you need people to advise appropriately about the personnel that you need. So again, we are losing so many people to amputations. If we get some of these devices, and there were one or two people in the private sector providing, and there still are people in the private sector who are providing these devices. So if it's available in the private sector, surely we can provide some of these devices, because the cost of an amputation, can I just repeat that? The cost of an amputation in terms of economic cost to the government service as well as to the patient. Obviously, that patient may lose their job, they become dependent, so the economic burden on the economy, and then the long-term effects on that patient. Many people who have had amputations become depressed, etc. It's well worth investing in multidisciplinary teams, and that's what we are doing at the Anaposa Center. We are in the process of putting together a more formal multidisciplinary team in the next few months, where we would have a podiatrist, we would have a diabetes educator, and we'll be working alongside other healthcare professionals very closely. So keep abreast of those developments. Right now, I refer people to other places, but hopefully on one site, we will have all these healthcare professionals working together so we can develop a holistic care for our diabetics. I want to show slide 11, and this may come as a little bit of a shock, this particular slide, because it shows a diabetic, and you can see that there's a nail or a long object going right through the foot. And this is called the painful nature of diabetic foot disease. So what happens with diabetic neuropathy? This person may have sustained this injury, and of course, they would probably know that it's there because it's such a big object, but very often there are smaller devices in people's shoes, etc. But the key thing about this is that this would be relatively painless because the patient has lost sensation in the feet. The next slide, slide 12. Slide 12 shows us, if you look carefully, the patient has already lost 2 toes. And if you look at the left-hand side of the slide, you see that area where the toes are missing. You see hard skin building up because the whole mechanics of the foot has changed. And there's an area lower down on the slide where the skin is broken. So when toes are lost, the whole mechanical nature of the foot is changed, and that is a high-risk foot. I'll show you another slide, slide 13. Slide 13 shows how not just the sensory nerves, but the motor nerves in the foot are affected. You see wasting of the muscles between the toes. So you can see between the toes, and then you can see the nails have become very dystrophic. And if you look very carefully on the right-hand slide, you see the second toe in particular is clawing. So it's forming a claw, and all the pressure is going to come under that area, that second toe. And that second toe will be a toe that is at particularly high risk. And slide 14, you see that there's localized callus buildup on the left-hand side of the foot that's on the left. You see at the extreme left, you see hard skin building up on the toe, as well as just under the toe, that's over the metatarsal areas. You see clawing of all the toes. The toes are clawing over, and then you see the skin is breaking down, and a diabetic foot ulcer is developing. And the last slide I'll show you for now is slide 15. Again, you see very hard, dry skin, and I'll explain that in a moment. Very hard, dry skin. So you have what we call autonomic nerve damage. So the skin becomes very dry, and the skin is cracking, and then an ulcer can develop in that area. So I'll just come off that slide for a minute. So what I've showed you there is a variety of foot problems. So there was a diabetic neuropathy, the painless neuropathy that we started with, and then you went to a motor neuropathy where you have wasting of the muscles, and then you had autonomic neuropathy where the skin becomes very dry and you have cracking and the skin becoming very prone to developing ulcers. Well, time is going very quickly. We have to go to our second break. So we'll go to our second break, and then we'll return to Your Health, Your Choice.
Looking for a safe place for the whole family? Well, now you found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values, and family first. We are ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. Tonight we're discussing a very important complication of diabetes, and the reason I'm revisiting this is because a lot of people present us with diabetic foot disease, diabetic neuropathy, diabetic sensory neuropathy, the nerve ends being affected, but you can also have a diabetic motor neuropathy, and you can have a diabetic autonomic neuropathy affecting the feet as well. And at the start of the program, I explained the different types of neuropathy that you can have in diabetes. But the feet itself can be affected by all those different types of neuropathy, but the typical symptoms of very painful feet, very burning, crawling on the feet, shocking sensation, It's extremely distressing. Some patients can't sleep at night, and there are various treatments that can be offered. Now, I want to say the treatments are not easy. When I say that, sometimes we have to try different things until we get the right treatment, but the basic emphasis is on getting the diabetes under control, getting the blood pressure under control, getting the cholesterol under control, and then trying to treat the nerve ends. And there's often asked, can you reverse the damage that has been done? Well, that's a big, big question, and a lot of research is going into it. So I would just be to say to you that our emphasis is controlling the symptoms. And I know, yes, I know, there are people out there who will claim that they can reclaim or bring the nerves back alive. Be very careful who you go to and who you are getting advice, because you could end up spending thousands of dollars through the false claims that often come through our television screens and our radio programs, etc. People claiming that they can bring the nerves back alive. What we can do is try and limit the injury and try and control the symptoms. And of course, the emphasis is on early good control. So I'm going to go just touch, because time is going very quickly, on peripheral vascular disease. So we're going to go to our last clip. We're going to look at a condition that often overlaps with diabetic neuropathy that makes diabetic foot disease very, very difficult to treat at times. So let's just talk about peripheral vascular disease.
Leg pain may be a signal that your heart is at risk. Do you sometimes have a tight pain in your leg when you walk or exercise? Ouch! Does the pain disappear when you rest, but return when you start moving again? Ouch! If the pain in your leg continues during everyday routines, it could be a sign of peripheral artery disease, or PAD. Ouch! PAD is what happens when arteries in the legs or feet become blocked with plaque, and it is a very painful and serious condition. I keep having these pains in my leg when I walk.
We should take a look at this.
People with peripheral artery disease are at greater risk for heart attack or stroke. Risk factors such as high blood pressure, high cholesterol, and smoking increase the likelihood of developing PAD. Symptoms of peripheral artery disease can include unexplained leg cramping while walking, slow healing leg or foot wounds, and other skin or nail problems with your legs and feet.
I'm thinking you need to make that call to our doctor, dear.
If you're experiencing persistent pain in your leg when you walk or exercise, visit your healthcare professional right away. Learn more about peripheral artery disease at www.heart.org/PAD. The pain in your leg could hold a clue about your heart health.
So, a very important point was made there. I am emphasizing the fact that peripheral diabetic neuropathy and peripheral arterial disease can often overlap. And as a result, you have poor nerve supply and poor blood supply. So the poor nerve supply leads to numbness, decreased sensation, and then you have patients at risk of developing foot ulcers. And then when a foot ulcer develops, if you have peripheral vascular disease, you have poor oxygenation of the tissue. Now, the way a tissue heals or an ulcer heals is that you have to have oxygenated blood coming to that area to allow healing. So if you have poor blood supply as in addition, and that is why I would tell you, if you have a diabetic foot ulcer, you need to see properly trained physicians. You know, we have seen at our center so many patients coming in, and they've been to healthcare professionals, and they've had a little debridement here and a little debridement there, and without realizing it, the foot ulcer is really fulminating under the skin. So one of the things to remember about diabetic ulcers, foot ulcers, it can be very deceptive. The reason for that is that sometimes the immune system doesn't mount the typical response to the injury. So someone who is not diabetic, if they have a cut or there's an infection, very often the foot will get very red, very inflamed, because the body is fighting off that infection, and the redness and warmth, etc., is really a warning sign that there's pus building up, and that that pus needs to be built, needs to be released, and an abscess could be forming. So I very often work alongside surgeons who, if I think antibiotics, etc., are not working, I'm not a surgeon, I don't go cutting into people's feet, I would refer you to one of my surgical colleagues, and that's where the multidisciplinary team comes in. Now, in diabetics, what happens is that the immune response is not what it should be, so very often it can be very deceptive. The foot doesn't look particularly red, there's not a lot of warmth there, and you could be deceived. That's why patients delay in coming in, because one, the foot is not as painful as it should be, because the foot is already numb. Two, even before that, because you may have not even noticed that the skin was broken down, especially if it's an elderly person and can't look under the feet. And by the time the ulcer is picked up, there's a delay, and by the time the patient comes in, if you don't treat this very aggressively, so I personally have a very, very aggressive approach to treating diabetic foot ulcers. I would begin treating very aggressively with strong antibiotics, etc. And if it's an open ulcer, I would often refer to one of my surgical colleagues. So the diabetic foot ulcer can overlap with peripheral vascular disease. And one of the things to note here is the statement that people with peripheral vascular disease, it can often be an indication of your heart health. Very important, because if you have blockage of your arteries to your feet, theoretically, you can have blockage of your arteries to your heart as well. And, you know, I can't overemphasize that. And that is why when I hear people talking about that aspirin is bad for you and cholesterol tablets are bad for you, I sometimes want to pull my hair out. I don't have much left to pull out, but I want to pull my hair out because, you know, it's simply such a poor understanding of the role of medication. Can I, you know, we're coming to the end of this program, and I probably will have to revisit this whole area of diabetic foot disease. But can I just say again that we are seeing the fallout of people trying to treat medical problems with non-scientifically tested treatments. Yes, there might be anecdotal evidence for some things. For example, I today just posted something on my Facebook page on the role of ginger. So there's some scientific evidence that ginger has a role. And some of you may say, well, we knew that all the time. Well, yes, you knew that, but the science was not there. So the way we should do medicine, that's why we send our young people to study medicine. If medicine was based just on anecdotal evidence, then we would not need to send our young people for 5 and 6 and 7 years of medical school training. If you could just pick up a blog and begin to think that you are an expert at treating medical problems, then you know, medicine would be much easier. But medicine has to be done on the basis of science. And science is on the basis of placebo-controlled double-blind studies. Now, there's one other condition I want to mention to you, and this is slide 19. This is called Charcot's arthropathy. And this condition, you have increased blood flow to the feet, you have artery vein shunting, it's called, you have bone resorption, and it's very, very commonly misdiagnosed. I'm just going to show slide 20 very quickly. Acute versus chronic Charcot's arthropathy. So very often people come in with Charcot's and it's treated as a cellulitis. With an acute problem, it's unilateral, warm, swollen, relatively pain-free, bounding pedal pulses, deformity may be present, but a chronic Charcot's can have no temperature differences. It's a rigid form deformity, foot deformity, and it's a grossly misshapen foot. So acute versus chronic Charcot's. So you can have an acute Charcot's versus a chronic Charcot's arthropathy. And it's a condition that needs to be looked at. And let me just show slide 21. in closing off this, you can see on the left side of the slide, the bones are very disorganized in Charcot's. And on the right side, the foot is typically, the foot is all out of shape, and it's swollen on one side. And therefore, that foot, there's an extreme risk of ulcers developing. I just want to come off of that slide. So I've talked a little bit about diabetic neuropathy overall, diabetic motor neuropathy, diabetic sensory neuropathy, and diabetic autonomic neuropathy. And I have gone more in depth in diabetic sensory peripheral neuropathy, which is affecting the feet and the hands. And we have talked a little bit about peripheral vascular disease, which can overlap diabetic neuropathy. And also, we have talked about peripheral vascular disease. Now, can I just, as we only have about 5 more minutes, just close up by saying that there are treatments for diabetic neuropathy. So a lot of patients come in with very, very painful neuropathy. Can I say a lot of the talk of detoxing, you know, putting your feet in water and the water going brown, there's been some, you know, some surveillance over this, and some real con artists are out there getting you to put your feet in water, the water goes brown, and you think you're detoxing yourself. I bet you everyone who puts their feet in that water, the water goes brown. So that is not going to help your neuropathy. There might be some herbal treatments that may help. One of the treatments that I sometimes use first line is something called alpha-lipoic acid. There's some weak science, it's an antioxidant, but very often we have to go on to more powerful drugs, things like Cymbalta, gabapentin, amitriptyline, which is actually one of the older drugs available on CDAP, Lyrica, and very often when I mention Lyrica, people immediately say, no, I'm not going to take Lyrica because I've heard about so many side effects of Lyrica. Yes, Lyrica does have side effects, but if you use properly, it's a relatively safe drug. And very often we have to combine one of those drugs with a painkiller like Tramadol or Panadine F. Let me say very quickly, I don't use things like Olfen, Cataflam, etc., non-steroidal anti-inflammatories in my diabetic patients because they can cause renal problems if used excessively. Short term, it's okay, but some of my patients have to stay on painkillers long term. So I use things like Tramadol, Panadine F, together with some of the things like Lyrica, Cymbalta, alpha-lipoic acid, etc. And of course, there's a role for physiotherapy in helping all of this. So as we come to an end, we showed a clip on our marriage conference that is going to be held on at the Anaposis Chapel. We are based on the bypass in San Fernando, number 12 Johnson Street in Coquille. You can see some big signs. Some of you may get confused because you see a sign for the Anaposis Medical Center. Eventually, we may move the medical center to that site, but for now, we are based at number 10 Lance Street in Vista Bella as our main center. And we are in the process of developing a multidisciplinary team where we have various people working together to deliver a holistic approach to diabetes care. So if you need more information about all of that, you can ring us on 482-4269, 482-4269. You can join me on Facebook, do a friend request on Facebook because I post a lot of medical articles, etc., on the Claude Khan, or you can follow me on Twitter. That's another way of seeing some of the articles. Or we have a YouTube channel, the Anaposis Chapel, where you can see some of the medical articles and some of the other things we do at the Anaposis Chapel. As I end today, I only have about 1 more minute, I think. Last week, Sunday, at our church, the Anaposis Chapel, I preached a sermon called From Exhausted to Energized. From Exhausted to Energized. And we used a scripture passage from Luke chapter 10, where it's a famous passage where Jesus went to the home of Mary and Martha. And Mary was willing to sit at the feet of Jesus. And Martha, on the other hand, was extremely busy trying to prepare a meal. And Martha eventually approached Jesus and said, Jesus, don't you care about me? I want to say to you today that sometimes our lives become very cluttered. and that sermon came from a book called Simplify. I think there comes a point in our lives where we need to simplify our lives. We need to look at the things that are probably good, but not the best for us. So can I say that again? There are many good things we can be doing, but very often God has better things and the best things we should invest our lives in. And the way you can re-energize your life is by connecting to God. And that might be in solitude, might be in your garden, might be through music, might be through reading God's word, might be gathering together with other people, surrounding yourself with people who can energize you. There are toxic people who will drain you. There are people who are toxic that can de-energize you. And then, of course, your work, your daily work, should be one that should fill you up with energy. So why not move from being de-energized to being unexhausted to being energized in 2019? So as we end this program, I just want to remind you, you can look at this program on Thursdays on this channel at 1 p.m., Sunday evenings from now, new time from 6:30 to 7:30, and Wednesday nights at 8 p.m. You can also join us on the YouTube channel, the Anaposis Chapel, but the ACTN channel, the YouTube channel, to look at some replays of this program. And of course, you can follow us on Facebook as well. And then we come back with new programs in 2 weeks' time. You can ring us on 482-4269 for more information about what I've talked tonight. Thank you very much for joining us on Your Health, Your Choice.